Very good evening to everyone. I am Dr. Shubham and I take this immense pleasure to introduce one of my very dear seniors. He is one of the, one of the legends of therapeutic endoscopy in the country. He is Dr. Sawan Bopanna. He is a senior gastroenterologist, senior consultant with Max Hospital Saket at the moment. But we started our journey way back 5 years ago when I joined my first job post DM at Fortis Vasankunj for 2 months, and then I left. But the best part about him is that he's absolutely approachable and he's one of the masters of EUS and ERCP. And I literally I'm a fan of his work. He did his MBBS from KMC Manipal, did his MD from Sabdajan VMMC New Delhi, did his DM gastroenterology from AIMS, and has been practicing for now over 10 years. And I think there can be no better person to talk about pancreas, being trained by Dr. Pramod Garg. And I take this immense pleasure again to welcome him to this forum. And sir, we look forward to your expert comments on this topic. Thank you so much.
Thank you, Shubham. At the outset, I would like to thank this forum for inviting me here today and for all the kind words that Dr. Chavan and Dr. Shubham have bestowed on me. So the topic that I'm going to be speaking about today is management of pain in chronic pancreatitis. So chronic pancreatitis is a disease which is close to my heart. It's not as common as the most commonly seen acute pancreatitis, but chronic pancreatitis patients have the disease for life. And they go through a course which is sometimes stormy, sometimes indolent. But most of these patients keep going in and out of the doctor's clinic every 2-3 months, every year. And sometimes they have complications, sometimes they have very poor prognosis. But one thing that really troubles them is the pain, because it's the pain which actually hampers their daily working. And even though chronic pancreatitis is not a deadly disease, in fact it's something that lingers on for years and years, the understanding about chronic pancreatitis is very much lacking even in research circles and even in the most top institutes in the world. And chronic pancreatitis is a disease in which from India there's been a lot of work that's been done. So my initial few slides will just be a recap of the basics of chronic pancreatitis, followed by the main topic, that is management of pain in chronic pancreatitis. So we all know the causes of chronic pancreatitis. The most common cause is of course alcohol and smoking. And in India, the second most important cause are recurrent attacks of acute pancreatitis. Most of the times it's due to genetic mutations. And the other less common causes are sometimes autoimmune pancreatitis, hereditary pancreatitis, and very rarely cystic fibrosis. So in my talk today, I will be speaking about the etiology, clinical presentation and diagnosis of chronic pancreatitis, the Indian data that we have. It's very important that we understand the Indian data because most books and most articles that we read are from the West. And the chronic pancreatitis that we actually see in India is very different from what is seen in the US or Europe. And the pathogenesis of pain in chronic pancreatitis, we have something called as the oxidative stress within the pancreas, because as we all know, the SNR cells within the pancreas metabolize a lot of substances in the body, including some of the drugs, and it is a site of extreme oxidative stress. And this oxidative stress within the SNR cells in the pancreas has a role in pain and also in the progression of chronic pancreatitis. And then some basics about medical management, the role of antioxidants, because oxidative stress is the cause, and a very few slides on endoscopic treatment options that we have in chronic pancreatitis. So chronic pancreatitis is a progressive disease, basically an inflammatory disease of the pancreas. It's characterized by two main things. One is fibrosis and recurrent inflammation of the pancreas. Over a period of time, it is characterized by pancreatic atrophy, fibrosis, strictures in the duct. The duct gets destroyed, there are calcifications, very rarely you can have dysplastic foci appear in the pancreas, and definitely exocrine insufficiency, that is steatorrhea, diabetes and chronic pain. And the prevalence of chronic pancreatitis varies widely in the population. The most common classification that we use in chronic pancreatitis is the Tigaro system. So it basically classifies pancreatitis based on the etiology of the cause. So whenever you have a patient who is presenting to you with recurrent episodes of pancreatitis, you have to rule out these causes, which is the mnemonic, which is Tigaro. So you have toxic and metabolic causes, alcohol, smoking, sometimes increased calcium. Hypoparathyroidism is caused by hypercalcemia. leads to chronic pancreatitis. Then you have hyperlipidemia, hypertriglyceridemia, and chronic renal failure. Idiopathic is one of the most important causes of pancreatitis or chronic pancreatitis in India. It was previously called as tropical pancreatitis, and very famously, tropical pancreatitis is a disease of South India. But we do see a lot of tropical pancreatitis in the north also, and this is now being called as idiopathic chronic pancreatitis. Then we have genetic causes, autoimmune causes, recurrent and severe acute pancreatitis. For example, you have a patient who has one episode of gallstone pancreatitis, and most of the pancreas gets necrosed, and those patients also may present as chronic pancreatitis. And very rarely you have obstructive causes. The normal drainage or the normal pancreatic duct drains to the ampulla of Vaisya, but sometimes you have malformations which lead to the obstruction of this duct. It's called pancreatic division, where the main pancreatic duct will drain into the minor pancreas. And there, because of recurrent obstruction, the pancreas may get destroyed and it may cause chronic pancreatitis. So what are the symptoms that we commonly see? Pain is the most common presenting symptom. Patients come with recurrent epigastric pain radiating to the back, lasting for several hours to days. Patients cannot eat anything and they have to go down or bend down to relieve the pain. That's the most common presenting symptom, abdominal pain. And in clinical practice, we also see patients coming with recurrent episodes of pancreatitis. You have one pancreatitis, you discharge the patient, they come with another episode. So acute pancreatitis and recurrent acute pancreatitis are the second most common presenting features. And then the third and the fourth, you already know, exocrine insufficiency or diabetes. So either patients sometimes become only with diabetes and you find they have chronic pancreatitis, and sometimes patients may have diarrhea, loose motion, steatorrhea. And on investigation, you may find that it's the pancreas which is not producing any enzymes, and therefore the patient has chronic diarrhea. So how do we diagnose chronic pancreatitis? This is something which is very commonly mistaken. Patients with long-term symptoms, acute pancreatitis, are sometimes falsely labeled as chronic pancreatitis. So the most important thing to actually confirm and label a patient as chronic pancreatitis is to look at the pancreas, that is imaging. So on imaging, if you have calcifications or a dilated duct, the pancreatic duct is dilated or there is calcification, then you can easily 100% say that this patient has chronic pancreatitis. So CT, simple CT is the diagnostic modality of choice to diagnose chronic pancreatitis. Now when you want to assess further and when you want to actually look at ductal changes before any therapy, or you want to look at the ductal malformations to find out the cause, and then an MR or MRCP can be done. And for very early pancreatitis, sometimes patients have recurrent acute pancreatitis, CT does not show any calcification, CT does not show any ductal dilation. So there, endoscopic ultrasound has a role when you feel that this patient has chronic pancreatitis, but none of the investigations are able to diagnose it. So then you have an endoscopic ultrasound, which is the most sensitive and specific test for diagnosing pancreatitis. So in an endoscopic ultrasound, we get a very clear image. I'll show you in the next few slides. A very clear image of the parenchyma of the pancreas and also of the duct. So we can see all the anatomical features of the pancreas, and therefore, with great confidence, diagnose a patient with chronic pancreatitis. We must remember that chronic pancreatitis is a diagnosis for life, and therefore, before we label a patient as chronic pancreatitis, it is very important to make sure that we have done our diagnostic modalities in the right way. So, in a contrast, so the first step when you have a suspected patient presenting with abdominal pain, diarrhea, or first episode diabetes, along with pain and pain, to get a CT done. So if the CT confirms pancreatitis, that there are any calcifications or characteristic pancreatic duct changes, then the diagnosis is made. But then if it's negative, but there is a high probability of disease, then you can go ahead and look at it with an MR and look at the duct. Basically the MRI tells us more about the ductal anatomy. And if you see a dilated duct or a strictured duct or a destroyed duct, then again you can make a diagnosis of chronic pancreatitis with confidence. But sometimes there are none of these features, the parenchyma and the duct are well maintained, and there you may need an endoscopic ultrasound to actually look at very early features of chronic pancreatitis. And once you made a diagnosis of chronic pancreatitis, we must assess the cause for pancreatitis. Many a times it's just alcohol or tobacco use. And many a times in India, where young people, males actually in their second or third decade present with chronic pancreatitis, it's generally what we call as idiopathic chronic pancreatitis, which previously was called tropical pancreatitis. So this is how pancreas looks once it's been destroyed. So you can see the stones filling up the entire pancreas, and you can see a hugely dilated duct. And the entire pancreas is just atrophied and there is a small pancreas. So this is how a classical picture of chronic pancreatitis happens. So studies from India have come from big centers to look for the etiology and the natural history of chronic pancreatitis in India. And as I said, they found, this is a study from Calcutta, and they found that the most common cause in India is basically idiopathic, and it's even more than alcoholic chronic pancreatitis. And most of these patients have calcific pancreatitis, but very few may have non-calcific chronic pancreatitis. And it is this subgroup of patients who do not have calcifications are difficult to diagnose on imaging and may need an endoscopic ultrasound. So pain is the predominant symptom in India, diabetes, steatorrhea, and sometimes complications like formation of the pseudocyst may be there on imaging. Many patients with chronic pancreatitis over a period of time develop jaundice. And when a patient with chronic pancreatitis develops jaundice, we must be very careful to rule out benign biliary strictures. So the bile duct moves through the head of the pancreas. So when the pancreas is destroyed, the bile duct gets obstructed. So a patient with chronic pancreatitis and jaundice, so we have to suspect that the bile duct is getting obstructed because of a benign biliary stricture in the intrapancreatic portion of the CV. So sometimes you may have patients presenting only with jaundice and they turn out to be chronic pancreatitis. So some of the commonest radiological findings in India, what they found is of course pancreatic calculi, dilated PD, atrophic pancreas, and sometimes even a stricture in the pancreatic duct. And often idiopathic CP all over India is followed by alcoholic chronic pancreatitis as the most common cause of chronic pancreatitis. So it's not only alcohol, a lot of undiagnosed patients, young children with recurrent episodes of pain abdomen, actually idiopathic chronic pancreatitis. So what is idiopathic chronic pancreatitis? It is basically a form of disease where there are undiagnosed genetic mutations within the pancreas and there are recurrent episodes of acute pancreatitis. So what is the key pathophysiology and why does chronic pancreatitis occur? So there is cellular injury, basically the acini get injured, and that is the key genesis for pain and also for progression of disease. Now this cellular injury to the acini brings in inflammation into the pancreas and eventually there is fibrosis. So once the pancreas is fibrosed, there is chronic pancreatitis. Now patients of recurrent pancreatitis have early disease, recurrent episodes of pain, and most of the time they have no imaging abnormalities. And in these patients who have recurrent acute pancreatitis but have not become chronic pancreatitis yet, to diagnose them early, EUS is the modality of choice. So this are some of the endosonographic images where you see that you can see a pseudocyst here, that is a collection, pancreatic collection. Here you can see the duct to be hugely dilated. This is the main pancreatic duct and this is the accessory duct, and you can see a pancreatic calculi here. There's a stone which is obstructing the duct. And sometimes you may rarely find that in older patients there are pancreatic neoplasms or small tumors which actually mimic and present as chronic pancreatitis. Now in patients who have no imaging abnormalities, that is the CT and the MR are both normal, there again EUS or an endoscopic ultrasound may help diagnose chronic pancreatitis. So you can see the changes very clearly in the pancreas. There are hyperechoic foci, the hyperechoic strands, and you can see an irregular duct. So these features help us diagnose very early or recurrent acute pancreatitis. So we have a criteria called the Rosemond's criteria that we use in endosonography to actually classify patients with chronic pancreatitis and diagnose them. So what we're looking for is changes in the parenchyma and changes in the duct, to put it in a nutshell. And if these key features are there, then we can diagnose chronic pancreatitis. So endoscopic imaging, other than finding out chronic pancreatitis, sometimes you can find CBD calculi in these patients because of chronic obstruction to the bile duct. And sometimes you can biopsy if you find abnormal lesions in the pancreas. And very rarely for therapy, we can also use a celiac plexus block, which we can do endoscopically for pain. Now, pain in chronic pancreatitis is the most prominent complaint, but it is poorly understood, the genesis of pain, and therefore treatment is also poorly understood. So there are several studies which have classified the type of pain in various patients. We have some patients who have episodes of pain, but they are controlled by medication. And there are some patients who have constant pain and they get controlled by medication. Sometimes patients are pain-free, but they have episodes of severe pain and they get relieved by medication. And some patients have constant mild pain and some patients have constant severe pain. So most of the time in clinical practice, we see patients with constant mild pain and intermittently they have severe episodes of pain. And secondly, we see patients who are generally pain-free, that is they don't have pain, but suddenly every 2 to 3 months they have an attack of pancreatitis. So to classify the mechanisms of chronic pancreatitis, we look at as plumbing problems, wiring problems, or extra pancreatic or pancreatic complications. So when I talk about plumbing problems, it means that the duct has a problem, the pancreatic duct. When we talk about wiring problems, it means that the nerve supplying the pancreas has problems. And also there are a lot of complications of recurrent inflammation or recurrent pancreatitis, like pseudocyst or a duodenal obstruction, bile duct obstruction, splenic vein thrombosis, peptic ulcer, which can occur as a process of a chronic disease. And these things need to be handled to actually treat pain properly. So treating pain in chronic pancreatitis is understanding whether it's a plumbing problem, a wiring problem, or whether there are any complications which are causing pain in the patient. So plumbing problem is actually a very mechanistic understanding of pain, or an easy understanding of pain that we can do if this is the cause of pain. And then you have central mechanisms of pain, which are central sensitizations, where because of a sustained pain, patients have pain throughout the year for several months. So the central threshold for pain comes down, and therefore the central mechanisms of pain need to be treated to actually get down the pain in some patients. And extra pancreatic causes, again, it could be pseudocysts, it could be obstructions, and these causes should be treated and looked for if we have to manage pain in chronic pancreatitis. So, as I mentioned, there's a lot of emphasis that is given on oxidative stress. So, it's basically imbalance between the pro-oxidants and antioxidants that are there in every cell. And this balance causes an inflammation and a neuroimmune alteration within the pancreas and generates pain. So we all know about redox status and oxidative molecules that are present. It's the mitochondria which actually generates these molecules, and when there is an imbalance in this homeostasis, that's when pain is generated. So what are the goals of medical treatment? So whenever we have a patient with CP, we have some of the important components of managing that patient. And pain management is of course the first thing. Second is to recognize and manage pancreatic exocrine insufficiency. Third is to monitor for diabetes. And fourth is to manage the complications like any duodenal obstruction, bile obstruction, or any presence of pseudocyst or infections. We need to take care of them to actually manage pain in these patients, and sometimes only medicines may not help. So if you have anatomical problems, what are the problems that can be there? It can be a pancreatic duct stricture, it could be stones in the pancreas. So we have therapies like ESWS, where you have shockwave lithotripsy to break the stones, and endoscopic therapy and surgery to remove these stones. And if you think that the SNR cells are actually the ones which are involved, then you have antioxidants that are available with us to treat pain. Now if you have problems, if you think the patient has sensory perception problems or nerve injury, again we have antioxidants and analgesics and tricyclic antidepressants and other gamma pentanoids that can help in controlling neuromodulation and therefore help in treating pain. And obviously to treat complications we have several endoscopic therapies. So long-term control of pain is difficult to achieve if you cannot really identify the actual cause of pain in these patients with chronic pancreatitis. So you have a lot of causes of pain. So you need to identify the right cause and then target your therapy to that to actually achieve some kind of relief in these patients. So identify the correct cause of pain and look at the change in character. Suppose a patient is completely alright for years together, suddenly develops a very severe episode of pain which is just not going even after months, then you have to be careful and look at for complications. Sometimes in older patients you can also find pancreatic malignancies in such patients. And look for alternate causes of pain. If patient has chronic pancreatitis, he can have other causes also, like peptic ulcer disease. So when a patient is not responding to your treatment, also look for other causes of pain, also complications of pancreatitis, like biliary obstruction, pseudocysts, and as I mentioned, some patients may also have malignancy if they have very severe pain. Now, what are the options available to us in the medical management of pain? You have to modify behavior that may exacerbate natural history of disease, mainly abstinence from alcohol and abstinence from smoking. because both of them can actually aggravate inflammation within the pancreas and cause pain. Avoid heavy and fatty meals. So patients generally should avoid heavy fatty meals which can trigger attacks of pancreatitis. And pharmacological measures that we have an analgesics, antioxidants, pancreatic enzymes. So medicine-wise, these are the three options that we have. So coming to the pain management with analgesics, so it has to be a stepwise approach. So we follow the WHO analgesic ladder. We start off with relatively harmless drugs and paracetamol with a plus or minus NSAIDs. And when that doesn't work, we shift to weak opioids like tramadol. And even if this does not help us in controlling pain, sometimes we may have to add analgesics like fentanyl patch. So we know the difference between NSAIDs and opioids. Basically, the problem with opioids is the use potential. And obviously the problem with NSAIDs is the problem that can cause to the renal function. So opioids have their advantages, NSAIDs have their advantages, and both of them have their disadvantages. Opioids are generally sometimes necessary because you need strong analgesics, and short-term opioids can have to be used sometimes in these patients. And keeping aware that it's a drug which can easily be abused. Other than this, as I mentioned that sometimes the nerve or neuromodulation is also involved in the pain, and pregabalin and amitriptyline are some of the drugs which have been shown in trials to help patients who have chronic pain. Patients have pain every day, you're giving them adequate analgesia, still patients complain of pain, and in those patients we can definitely give pregabalin and amitriptyline and see if they respond. Now, pancreatic enzymes also have a role in treatment of pain. They have a primary role in treatment of maldigestion, but it's also been seen that coated and uncoated enzyme supplements in variable doses can be used to treat pain. So how do they act? So basically they inhibit the meal-related pancreatic secretion and therefore help in pain management. So what do? You give high-dose pancreatic enzymes, and that destroys the intestinal polycystic iron, and therefore reduces the functioning of the pancreas in response to meal. And therefore, they help in also pain management. So pancreatic enzyme supplementation not only helps in treating maldigestion and chronic pancreatitis, but also can help in treating pain management. So to ensure the efficacy when you are using pancreatic enzymes, you have to make sure that the enzymes actually regulate the duodenum. And generally, here they have seen that uncoated enzymes, which are recently available in the market, previously they were not available in India, and most of the enzymatic preparations that were available were coated enzymes. So you generally use uncoated enzymes, so they get released in the duodenum. And in order to prevent these enzymes from breaking down the stomach, you have to use them along with the proton pump inhibitor. So the acid otherwise will destroy the uncoated enzymes. So there are several studies which have looked at the role of pancreatic enzymes in pain management, and they've all shown some benefit. Now, antioxidants is another option that we have to actually treat chronic pancreatitis. I've already gone through this. It's an imbalance which causes, there is increased oxidative stress, and there's reduced substances which actually antioxidants, that is reduced antioxidants. So what we can do is supplement the antioxidants like high-dose vitamins, vitamin C, vitamin E, methionine and selenium, which are actually micronutrients, which are essential to actually maintain adequate levels of glutathione. So glutathione is a very potent antioxidant. So by maintaining these antioxidant levels within the SNR cells, the oxidative stress can be brought down, and therefore patients have relief in pain. So this is one of the landmark trials. It's basically published from the All India Institute in Gastroenterology, which is the journal for gastroenterology. And it was a placebo-controlled trial. We looked at a fixed antioxidant combination, which included organic selenium, ascorbic acid, carotene, tocopherol, and methionine. And generally, the pharmacological preparations that are available to us today also contain this preparation only. And they found that most of these preparations, they help in reduction in the number of painful days per year, reduction in the number of analgesic tablets per month, and also the proportion of patients who remain pain-free while on antioxidant supplementation. So various studies even from the West have shown similar results that antioxidant supplementation may help those patients who have a good pancreatic volume, that is they have good SNR cells,
they are young, and they have initial pancreatitis, where the pancreatic gland is still not completely destroyed, and they continue to have pain. And these are the subgroup of patients who will benefit from long-term supplementation with high-dose antioxidants. And now we have a lot of data and a lot of evidence to show. These are all studies which have looked at various combinations of antioxidants and various durations. Some of them have been given for 6 months, some of them have been given for 12 months. And all of them have shown some benefit in bringing down the number of painful days per year in a patient with chronic pancreatitis. So that's about the medical therapy. We have 3 main options, either painkillers, either pancreatic enzymes, or antioxidants. So these are the 3 main medical therapies that are available to us to treat pain. Now when medical management fails, then we have to move on to other options. And once we have ruled out the complications like pseudocysts or other causes of pain, then we look at other options for treating pain. And the blockage of celiac nerve or the celiac ganglion is one of the ways where you can get a temporary relief from pain. So patients who are just not settling for 10 days, 12 days with severe pain, even with analgesics, they can go ahead and do a CT-guided celiac block. And now with the endosonography also, US-guided celiac block can be done. So from the stomach, we actually visualize the aorta and the celiac axis, and we inject bupivacaine and quinocort, that is triamcinolone, into the celiac ganglion under vision. And this generally gives temporary relief to most patients, and the relief may last for up to 8 weeks. And this actually buys us time in patients who are not responding to any kind of analgesia or any kind of medical therapy. Now, there's a lot that we hear about pancreatic ERCPs and pancreatic endoscopies. I will not really go into the details of it, but just one slide about pancreatic endotherapy. So, whenever you have a ductal obstruction in the pancreatic duct, so that may be due to stones, that may be due to strictures. So, in patients who are refractory to any medical management, even after 3 to 6 months, an endoscopic therapy may be offered to patients in whom you find this obstruction. So it may not actually help everybody, but in patients whom you find that there are calculi which are obstructing the duct and therefore dilating the duct, decompressing the pancreatic system many patients do have benefit of pain relief with the therapy. And what are the other things that you can find? You can find a stricture in the pancreatic duct which you can dilate with the balloon. And then you have stones within the pancreatic duct which are obstructing the duct basically. You can remove them. And most of these patients are put on stenting. And in patients who do not have a response to medical therapy, placement of a stent within the pancreatic duct may help relieve pain in these patients. Surgical therapy is also a very good option, especially in patients who have a dilated duct and a large number of stones. A one-shot surgical therapy may help, but generally it is a big laparotomy. The entire abdomen is open, the pancreatic duct is open, and the jejunum is attached to the pancreatic duct. This is called as an LPJ or lateral pancreatic jejunostomy. Most patients are generally, called the French surgery, and most patients are generally not willing for such an extensive surgery because the response was also very unpredictable. Some of the patients, even after such a big surgery, may not actually respond and they still continue to have pain, especially in patients who have alcoholic pancreatitis. So managing chronic pancreatitis pain, so you have to have a good diet, avoid fatty meals, you can try non-opioid analgesics, trial of antioxidants, pancreatic enzymes, cessation of alcohol and tobacco. And if the pain is relieved, yes, then you continue on your medical management. Around 30 to 40% of patients can be managed only on medical management. If they're not, then you look for patients whether they have any ductal obstruction, whether they have a problem within the pancreas or the pancreatic anatomy is out. And now if you have that, then definitely an endoscopic therapy, or suppose you have stones within the duct, you can do an ESWL just like you would for the renal stones and try to remove the stones. And that may help a proportion of patients. And if all fails, a surgical option may be provided to the patient, provided the surgery is amenable, it's feasible. You need a large dilated duct for them to actually make an anastomosis with the jejunum. So if your duct is dilated and filled with calculi, and patient has recurrent episodes of pain, then surgical options can also be offered to these patients. So I would like to summarize my talk and wrap up. With intense abdominal pain as a dominant feature of chronic pancreatitis, and this is associated with poor mental and physical quality of life. Abdominal pain is a result of a complex interplay of several mechanisms, as I just went through. So it can be at any level, and therefore abdominal pain in chronic pancreatitis, not all abdominal pain are the same. And we need to actually dissect and understand what is the cause of the pain to adequately treat the patient. And it needs a multidisciplinary approach. You need an endoscopist, you need a surgeon, you need a radiologist to actually look at what is the cause for this pain coming again and again. And only then we can actually target what is important and give relief to the patient. So medical management, we have three options as I previously said, either painkillers or analgesia. You have pancreatic enzyme supplementation, which helps quite a few patients, and antioxidants. Several trials have shown that something as simple as supplementation of antioxidants like high-dose vitamins do help many patients with recurrent episodes of pain. And several studies have, as I said, several studies have supported the use of antioxidants as part of the treatment regimen. And when medical management fails, of course, we have endoscopy and surgery. Thank you.
Dr. Sawan, thank you so much for such a well-explained talk. And before I open the...
Why don't you come and sit there?
Please, sir, have a seat. Before I open the stage for questions, I just want to ask you...
Give him some pre-medication.
Yeah, we have taken care of that. But I want to ask you, as a gastroenterologist, I want to hear you. But as a gastrophysician, they want to hear you. So can you just explain me the basic role of enzymatic therapy, the mechanism, how it works? Because I don't want to speak that out, and I know you are the master of that, so I want you to say that out. That why you should use enzymes, whether they are not coming from inside the body, why are you providing them outside the body? And you talked about a very important thing which I am sure majority of the audience missed. Uncoated and coated, and uncoated used with PPI. So I want you to stress on that point because that is a very important take home for our friends out here.
So pancreatic enzymes have two major roles. One is the treatment of maldigestion. So basically, if there are no pancreatic enzymes, the digestion is poor. So we're not talking about that. So maldigestion, I'm sure all of us know that if the patient has lack of enzymes, you supplement the enzymes, therefore digestion becomes okay. What we're talking about is the role of pancreatic enzymes in managing pain. So even in the management of pain, pancreatic enzymes have a role. This is because, as Shubham asked, so what happens is when food reaches the duodenum, there is secretion of cholecystokinin and secretin from the duodenal mucosa. And this stimulates the pancreas to secrete enzymes like lipase and amides. So what we need to do is bring back this feedback. That is the cholecystokinin which is secreted from the duodenal mucosa needs to be eliminated. And therefore, you need pancreatic enzymes. When you give pancreatic enzymes from outside, there are two more main actions that occur. One is the duodenum senses the enzymes and feels that it's enough, and therefore cholecystokinin does not increase, and therefore pancreas is not stimulated. And second, the uncoated enzymes destroy the cholecystokinin which is produced from the duodenal mucosa, and therefore bring down the stimulation of the pancreas. So pancreatic enzyme supplementation for management of pain basically acts by reducing the stimulation of the pancreas. Now there are two enzyme formulations which are available. One is the uncoated and the second one is the coated. So several years in India we did not have an uncoated formulation, and all that the major companies actually had, including Pancreatitis, was coated. It was a coated. Now with coated, it is a pH release mechanism, and the coated enzymes generally release beyond the duodenum. So they basically help in digestion. But what we need is enzymes which release in the duodenum itself, not beyond. Therefore, you need an uncoated preparation, which is now available along with Pancreatitis, uncoated. So uncoated enzymes reach the duodenum and therefore will prevent stimulation of the pancreas.
Can I just simplify what you say? मतलब एक मिनट के लिए मैं हिंदी में बताता हूँ. सर की भाषा बहुत ज़्यादा sophisticated है. Basically, pancreas से enzyme नहीं बन रहे, तो डुओडेनम कोलेसिस्टोकाइनिन और सिक्रेटिन बना रहा है कि और बना, पैनक्रियाज नहीं बना पा रहा, वो और बना रहा है, पैनक्रियाज स्टिमुलेट हो रहा है, दर्द हो रहा है। तो मैं बाहर से एंजाइम दे रहा हूँ उस फीडबैक रेगुलेशन के लिए कि कोलेसिस्टोकाइनिन और सिक्रेटिन जो आई सेल सीसीके बनाते हैं और एच सेल सिक्रेटिन बनाते हैं कि भाई मत बना, मेरे बस की नहीं है और एंजाइम बनाना, तो बाहर से दे दे। अनकोटेड दूंगा तो ज्यादा इनहिबिशन होगी, बट क्योंकि गैस्ट्रिक एसिड उन्हें डिस्ट्रॉय कर देगा तो साथ में पीपीआई देना पड़ेगा। तो एक्सोजीनस एंजाइम में सिर्फ फीडबैक रेगुलेशन को जो नॉर्मली नहीं हो पा रही उसको नॉर्मली दोबारा लाने के लिए बाहर से दे रहा हूँ। ठीक बोलो अब आप। So I think Dr. Sawan says कि मैंने Schlesinger अच्छे से पढ़ी है, and these are the lines from Schlesinger which is our Bible of gastroenterology, and I think even you love that book, you know.
Yes.
So we are just what do you call disciples and students of gastroenterology and Schlesinger and Fortran gastroenterology. So I would open the audience for questions, and we welcome all the questions to be answered by Dr. Sawan Bopanna. Thank you so much. Any questions, please? Sushil sir? The Dr. Saurabh Bansal has a question.
Mic, please, mic.
वही होता।
माइक आया?
Sushil sir, open to.
Mike Tyson।
Saurabh is a consultant laparoscopic GI surgeon in Gadara.
Yeah, a very nice presentation, Dr. Swapna. But I will have two comments and I will refrain from certain statements in your presentation. The first thing is the textbooks also say that the earlier you do surgery, you cut down the morbidity of the patient by pain as well as diabetes. Second, we are all doing nowadays laparoscopic LPJ as well as Berger's procedure as well as end-to side pancreatitis genostomy. So, and third, I have done in last 2 years almost 11 LPJs, 9 in Gangaram, 2 outside. 6 were stented. They have failed stenting, and the worst was it was stented 8 times, including the all named hospitals of Delhi. So I strongly believe that the earlier the patient gets in surgical management, if he got a dilated pancreatic duct, and if he has a pancreatic headstones, a laparoscopic Berger's procedure, so he does absolutely fine. I have the data of all 11 patients. In fact, one of our videos got selected for SAGES also, USA. So somehow I conflict with that statement that
Which statement?
that surgery can be done only open, it's a large surgery, we can discharge the patient on the 4th day. Second, the endoscopic management in this kind of a patient remains limited. Personally, I feel, because you need to change your stent, that you didn't mention. So I feel, see, every gastroenterologist has to change the stent after 12 weeks. And you immediately stimulating the pancreatic duct again and again. So I have seen also that during pancreatic stenting, there is a post-pancreatic stenting pancreatitis also. So you can share your experience. I have shared my experience. Don't take it otherwise. It's just an experience. No, I have no. It's not coming from the surgeon. I have closely working with entire gastroenterology department of the Gangaram Hospital.
That's fine. That's fine.
It's our experience, together experience.
Gangaram is a great department.
No, you are working in a great department.
So AIIMS in Delhi has some of the largest patient follow-up in chronic pancreatitis, and surgery is a very commonly recommended procedure even by gastroenterologists. It definitely works. Does great role, and some of the patients absolutely become pain-free with surgery. But also, you mentioned the problems with pancreatic stenting. There are also problems. So you have done 11 patients. It's a small number. And a large series, if you see, there are problems even with Frey's procedure, even with Berger's procedure, the pancreatic fistulas. You have to agree that the response is not 100%. Not all patients will become pain-free. There will be a significant amount of patients who even after surgery would not become pain-free. Definitely surgery is a very good option if you have a lot of parenchyma left, a large duct which is there, because you have to understand the pain basically comes from a parenchyma. So if you have a completely atrophic pancreas and the duct is full of stones, there even endoscopic therapy may not help and even a surgical therapy may not help. So the thing is, yes, surgery definitely has a role. It is definitely not, I never said that surgery is no role. Now, I will not agree with an early surgery preventing being the panacea for pancreatitis. So if you do an early surgery, it's not necessary the patient will not develop diabetes, not necessary that the patient will not have pain, not necessary that the patient will not. So of course there are a subset of patients who may. But that really to recommend surgery for every patient with chronic pancreatitis, I would still do. Now what is the role of endoscopic stenting? Yes, it is a temporary thing. Sometimes even after you do the stenting, even after you remove the stones, patients don't become pain-free. And then we have to refer them to you, and of course it makes surgery difficult because. So I think you have to take a call correctly as to which patients will benefit from surgery. And I don't think a blanket endoscopic therapy or a blanket surgery is the thing. So the gist of my talk was, we have to identify patients who will benefit from endoscopy, benefit from surgery, and benefit from medical therapy. So a lot of people are there who don't even want to try medical therapy. They don't believe in it. So, but there is a role. There is a role for surgery. There is a role for endoscopy. There is a role for surgery, definitely. But it's not that surgery is complication-free, but endoscopy is.
Before we have our expert speaker from the US to talk about this, sir, what is the concept about the pain getting burnt out?
Yeah.
So I have multiple patients stented for PD 6 times, 8 times. The eventual costs they pay for the surgery and the complicated surgery they face, and they without a stent, with actual data, having burnt out pain, like they are not having pain now. I don't know how it happens, nobody knows how it happens, but it is a known concept that chronic pancreatitis exists. And the second thing is, can I offer a surgery to a patient where on a CCT there is non-enhancing pancreas?
So, so just to this thing. So what he's trying to say is that many patients eventually end up having a burnt out.
Come here, sir.
So please. So eventually many patients have a burnt out disease. So endoscopic therapy may just offer an interim bridge before the disease eventually gets burnt out.
I agree to it. It's a multimodal management. I absolutely agree to it. But all the point I wanted to make it that the leak rate after ruined by pancreatic ostomy is absolutely low among all the pancreatic surgeries because pancreas is fibrous, calcified, the anastomosis rarely leaks. Even if you do Bloomgard everywhere, it is less than 2%. Luckily, we didn't have any pancreatic leak after LPJ or a Burger's procedure. Second thing is, I just want to clarify the audience that nowadays, with the instrumentation and with our training and all, we are all doing it laparoscopically and robotically with most of the bigger centers. I'm pretty sure that Max would be doing it. I'm pretty sure that Fortis people also, somebody will be doing it. Somebody at every institute is doing it. So it is absolutely a multimodal management. I would absolutely agree to it.
Dr. Sawan.
Dr. Bopanna, nice lecture.
Dr. Gautam.
Right.
I'm not a GI, I'm a pulmonary. So one quick question, non-obstructive chronic pancreatitis pain, where there is no endoscopic obstruction, what is the role of nerve block for controlling the pain? Any role of nerve block?
Yeah, I just mentioned that. Temporary relief.
Just temporary.
Temporary relief. It lasts because we use Ibuprofen and Triamcinolone. So we see that patients do have temporary relief up to 6 to 8 weeks. And then they again probably may come back. So it's all about buying time. You need the inflammation to settle down. So if with time the inflammation settles down, so after your celiac block, you may have a very good response.
No, we will have a comment from our gastroenterologist friend from US.
No, thank you. It was a great talk, and we all know for intractable pain in chronic pancreatitis, surgery plays a major role. So, in spite of having multiple endoscopic procedures, one of the, for long-term chronic pancreatitis, we are left with no option but surgical. So thank you for everyone's comments, and it was a great talk. Thank you.
Just a minute. Sir, Dr. Kantur sir. पीछे वाले एहसान मेरे दिल में तुम्हारा है दोस्तों, ये दिल तुम्हारे प्यार का मारा है दोस्तों.
Thank you. So in chronic pancreatitis, the pancreatic enzymes need to be supplemented for how long?
So if you're looking for maldigestion, obviously you'll have to supplement lifelong because the NCA2 is already set in. There's no other way the patient's going to release it. For enzymatic supplementation for pain, you can give a trial for 3 to 6 months until the pain settles down. So that's for every medical management. Even somebody may ask how long do we give antioxidants. So trials have given it for up to a year also. But the main trial that we follow is from India, that's from East. So it's basically they've tried it for 3 months. Generally we tend to give it for 6 months.
So can trial of cessation of pancreatic enzyme supplementation be done after 6 months?
Yes.
Because does pancreatic function pick up?
No, we're talking about pain.
No.
For maldigestion?
After an acute episode, it is impossible to realize, or is it possible to gauge whether this enzyme
for the first time in India, and I mean in classification, it's hardly seen abroad. It's something very, very impressive to the subcontinent.
So yes, so similarly, previously when we were all studying with tropical pancreatitis was released, we hardly see that subset of tropical pancreatitis nowadays. So large series from AIMS, they showed that tropical pancreatitis basically occurred because people were malnourished.
Yes.
And malnourishment was not because of tropical pancreatitis, but people were malnourished. So there was a phenomenon. Now you will see a good healthy person also with chronic pancreatitis. It is the same disease. But India at that time, because of poor nutrition, poor malnourishment, we thought that this is tropical pancreatitis. But now the same disease exists in cities, in urban areas where patients are fit and fine but still there. The mutations are in CFTR genes or in SPINK1 genes.
Sir, most of our physicians here, and we and gynecologist, our sister Dr. Shireen Madam, she's a gynecologist, eminent gynecologist. I wanted to ask 2 questions, sir. My first question is, we use a lot of DPP-4 inhibitors in our diabetes patients. Although there has never been a correlation between the use of DPP-4 inhibitors and chronic pancreatitis or acute pancreatitis. But there is an advisory on some of the DPP-4 inhibitors that in a documented case of pancreatitis, avoid using DPP-4 inhibitors. Your comment on that?
So I think endocrinologists the best. So our case, they do say that it has a risk factor. So DPP-4 inhibitors, they tend to avoid in patients who had. If suppose somebody has a gallstone pancreatitis, I think that's not the case. But suppose you use DPP-4 inhibitor, patient has pancreatitis, then obviously you cannot use it again. And for that same reason, I think they tend to avoid in patients who have. So that's not fibrocalcific pancreatitis. That is a different name. Fibrocalcific pancreatitis में pancreas ही नहीं है. So pancreatitis का मतलब कोई chance ही नहीं है. So there, but still I think the endocrinologists prefer insulin in those cases.
Can I have one or two? Just a minute. Let me complete the question. My second question is the correlationship risk factor of chronic pancreatitis and pancreatic malignancy.
So there is a definite this thing, but they're very small, as you're saying, 2 to 4%. That's the thing, and not everybody. So as I mentioned in my slide, you need to be very careful of the character of pain. The character of pain changes, and generally they're older patients. Like 50 years, 60 years, somebody has chronic pancreatitis for 20 years, now suddenly the pain is just not good, then you have to rule out the pancreatitis.
Dr. H.F. Kantur has another question.
In hyperlipidemia, there is pancreatitis. What is the pathogenesis behind it?
I don't really understand.
And then the question is, when we are giving medical treatment in chronic pancreatitis, the remaining tissue will get usually destroyed due to the disuse atrophy. Is it clear?
No.
Why not to do the surgical procedures of the remaining acinar cells and so this is not better to do the surgical and endoscopy procedures rather than to give the medical treatment for life? Should be enzymatic treatment should be for some limited time Otherwise there will be disuse atrophy of the pancreas.
नहीं अब सर आपको क्वेश्चन समझ लें डिस्यूज एट्रोफी क्यों होगा
एट्रोफी 90% ज्यादा हो
एट्रोफी का मैकेनिज्म जो है वो क्रॉनिक पैंक्रियाटिस की पैथोजेनेसिस
When pancreas, then we are giving enzymes. Because then stimulation of because
only
pancreatics, only listen to me sir, cholecystokinin and creatine, they are responsible for stimulation of the secretion from the pancreas, and it is usually you see with higher pH, it is basic to nature. So when we are giving enzymes, automatically the pancreas action, you see that giving cells will not act, that will be disuse atrophy. So how long we should give this medical therapy? That is my question.
So your understanding about this disuse atrophy, I would say it is little very 1 + 1 = 2 phenomena. But what we are saying is meal related stimulation. Cholecystokinin पूरा दिन में secreted पूरा दिन में secreted. And suppose if you remove cholecystokinin and secretin from the body, let's say completely, even then the pancreas won't suddenly become disused, and because there are so many other enzymes, so many other stimulants.
Can you explain it to sir over dinner?
I would love to.
Yeah, good. So, no, please, no offense meant to anyone. I come to Dr. Tulsi sir, and then Dr. M.L. Kalra sir. We need to wind this up at 10:25, please.
I think Shane had a question, a small one.
Sir, just a query. You explained that there is a group of antioxidant combination is given for the conservative management of chronic pancreatitis. Those reduces oxidative stress, and the strongest one is glutathione. Then why not to directly give glutathione rather than combination?
So there is, I don't think, a pharmacological delivery device which will lead to absorption and increase in the cells. So whatever we glutathione is one of the antioxidants. There are several other antioxidants, and all of them require these basic nutrients. The antioxidant wala jo kahani hai, it is some people believe it, some people don't believe it. But in lack of options, we've always found that in patients who have good parenchyma, मतलब अभी भी parenchyma अच्छा है, तो preserved है, उनमें काम करेगा, because cells अभी भी हैं. A lot of patients, lot of physicians don't believe it, lot of gastroenterologists say ये नहीं काम करता, but there are n number of trials. मतलब in personal experience, there are patients who become pain-free at least for some period. And this combination of somebody may say, why selenium, why can't you use some other thing, why vitamin C, why can't you use vitamin B? But there are a lot of bench studies and basic science studies इसमें बहुत हुआ है, which they looked at the levels of various nutrients. They found that these nutrients are deficient, and therefore they said, let's try with these nutrients, and then they found it works, and then it's been followed. So it's like there is no real hardcore kind of 1 + 1 mathematical thing to this, but it works in some and doesn't.
Ma'am, this was started by Dr. Rakesh Tandon, who I worked with at PSI for 3 years before may God bless his soul. And after that, taken after by a lot of people at AIMS and now by Dr. Anup Saraya. And these are randomized controlled trials which have seen effect, but there is no scientific data to say that this will happen in every patient. That's all we are saying. So there is more to be understood about all this.
Dr. Tulsi sir, please.
Thank you, Dr. Bopanna and Dr. Shubham. So those were some wonderful insights on chronic pancreatitis. So this seems to be a progressive inflammatory irreversible disorder, permanent dysfunction, endocrine as well as exocrine dysfunctions, which is irreversible. Now, tell us a little about the exocrine clinical manifestations. Would you say that it could be steatorrhea, then it could be weight loss, malnutrition, metabolic bone disease, and vitamin and mineral deficiencies? Of course, the risk of osteoporosis is at least 3 times higher. Tell us it.
The risk, you're right, the risk is higher. Clinical management would be symptom-based, basically. Weight, you'll have to check for weight, you'll have to check for the amount of stools. There is no guideline which allows us to titrate and exactly do it. But along with nutrition, enzyme and supplementation has been shown to increase weight, increase the level of micronutrients in the body, prevent steatosis. So you're right. So it's there are a lot of deficiencies. Osteoporosis is a very common presentation.
let me proceed further. So, hereditary pancreatitis. See, Dr. Chawan raised a question regarding risk of CA, pancreas. This is one modality. This is one. See, hereditary pancreatitis increased risk of CA pancreas is there as compared to idiopathic or alcohol induced. What do you say?
You're right. Again, so idiopathic is also managed and hereditary also. Idiopathic also has a genetic basis to it. So there are several studies which have shown that this subgroup of patients who actually are at risk. But there are a lot of studies which have negated that also. कुछ लोग बोलते हैं alcohol pancreatitis may be होता है. And there are patients who sometimes with alcoholic pancreatitis who may have an underlying genetic basis also. We don't know. Develop or manage.
So, Dr. Bopanna, tell us, how much is the minimum lipase that can be, the drug which needs to be given? Would you say it's about 40 to 50,000 USP units?
Yeah.
That's the minimum you need to get?
You need to give a large dose. Generally what we have with the pancreatin formulations. Pancreatic formulations have lipase measurements. They are either 25,000 or 10,000. So these are the formulations we have. So they should at least be 30,000 units and you titrate them upwards. You at least have 10,000 and then you titrate them upwards.
My last question, sir, regarding APECT. Now, APECT is autologous pancreatic islet cell transplantation. See, instead of total pancreatectomy, would you like to do this? Is it being done at your center?
No, I am not
seeing it. Is this a modality of choice in place of total pancreatectomy? Where is Dr. Shubham?
So basically, it's been suggested, total pancreatectomy has been suggested in patients with refractory pain. So
intractable pain.
Intractable pain.
Yes.
So they remove the entire pancreas and then they do autologous islet cell transplant.
Right. So
but I have no experience.
Thank you.
Dr. Kaga, sir.
Yes, sir. Sir, Dr. Tulsi, thank you for finishing early. Dr. Johan, sir, in retaliation to your comment, 2 kids and 1 wife syndrome, I would say, I find 57.3% present here, suffering from the same or say enjoying the same. Sir, my question to my learned friend Dr. Bopanna, sir, pancreatic transplant, is it also a possibility or a modality ever thought of in cases of chronic pancreatitis? Of course, we know for it is for type 1 diabetes at times.
Total pancreatectomy with autologous islet cell transplant. That is a modality, but I don't have experience with it. Neither is it commonly done. And if it was really working, it would have been done.
Pancreatic transplant.
His question is different.
Pancreatic transplant was different than autologous islet transplant. So my point was, is it a modality?
No,
in pipeline, or do we think?
No.
Nefopen or Ecupen is one of the non-opioid central painkiller. Do we use it in your practice or pain management?
No, I have not really used it.
Any role of antifibrotics in cases of cystic fibrosis?
Area of research.